Welcome to today's program, KDIGO Genetics in CKD webinar series. Episode 4, Implementation of Genetic Testing for CKD in the Real World and Clinical Practice. First off, some housekeeping notes. A link to the CME details and a copy of the slide deck is provided in the video description below. This activity is jointly provided by the Global Education Group and KDIGO. This activity is supported by an educational grant from Natera. The educational design of this activity addresses the needs of nephrologists and related specialists and allied health professionals involved in genetics and the treatment of patients with chronic kidney disease. The following is a program overview and covers the educational objectives. Join Professor Nina Knoers and Professor Andrew Mallett as they take a deep dive into the implementation of genetic testing for CKD in the real world and clinical practice. This enduring webcast describes how clinical utility is measurable for genetic and genomic testing in specific kidney diseases, looks at how testing can have subtle differences to research, and discusses how patient-centered approaches to genomic applications in nephrology are essential for implementation. In terms of educational objectives, after completing this activity, the participant should be able to describe how to go about implementing genetic testing for CKD in the real world, outline optimal workflow and infrastructural requirements, discuss how to communicate the implications of genetic testing with patients, describe how clinical utility is measurable for genetic and genomic testing in specific kidney diseases, and characterize how diagnostic and clinical utility are related, but can be different. The faculty for today's program are Professor Andrew Mallett, Director of Clinical Research and Nephrologist, Townsville University Hospital, Queensland, Australia. Second faculty is Professor Nina Knoers, Chair of the Department of Genetics, University Medical Center, Groningen, Netherlands. Here you can see the physician accreditation statement, the physician credit designation, the global contact information, and the term of this offering. Please here review the instructions to receive credit, the system requirements for today's program, and the fee information and refund and cancellation policy. We've also provided for your review the disclosure of conflicts of interest, and the disclosure of unlabeled use, and our disclaimer. At this time, I'd like to turn the program over to Professor Andrew Mallett. Go ahead, sir.
So on behalf of KDIGO and Professor Knoers and myself, good morning, good afternoon, and good evening for wherever you are. Thank you for joining us for this exciting webinar from the KDIGO Genetics and CKD series. It's a privilege, I think, today to be able to present this session on implementation of genetic testing for CKD. The real world and clinical practice is really our main bent, and I think we're really excited to walk through some practical concepts and looking forward to hearing your questions towards the end. Briefly, some introductions. As I mentioned, my name is Professor Andrew Mallett. I'm an adult nephrologist practicing in Townsville in the tropics here in Australia. It's a pleasure to introduce Professor Knoers. I'll hand over to you, Nina, to introduce yourself.
Thank you, Andrew. So my name is Professor Nina Knoers. I'm a clinical geneticist and currently the chair of the Department of Genetics in the University Medical Center of Groningen in the Netherlands. Thank you.
So briefly at the beginning, we'd like to outline the learning objectives for this session, because this is actually quite critical, we think. First of all, we're seeking to describe how to go about implementing genetic testing in CKD in the real world. I think this is quite important, and hopefully you'll get a flavour of this. We'll be outlining the optimal workflow and infrastructure requirements for this to occur, discussing about how to communicate the implications of genetic testing with our patients and, of course, their families, describing how clinical utility is measurable, actually, for genetic and genomic testing in specific kidney diseases. And lastly, we'll also be characterising how diagnostic and clinical utility are related, but quite importantly, are different in some dimensions. For the first section of the slides, I'll hand over to Nina.
Thank you very much, Andrew. So, as most of you probably know, is that monogenic diseases are actually an underestimated but very important cause of chronic kidney disease. By now, we know that genetic kidney disease is actually present in more than 70% of children progressing to renal replacement therapy. And this is also true to 10 to 15% of adults with end-stage kidney disease. And by now, we know that mutations in more than 600 genes are associated with inherited kidney diseases. And we also see that genetic testing is increasingly being used in the diagnostic process of patients with chronic kidney disease. So with the coming of the so-called next generation sequencing techniques, the diagnostic yield of genetic testing has significantly increased. So overall, we have seen in cohort studies that in about 30% of pediatric cohorts, there is a diagnosis in patients with known and unknown causes of CKD. And this is also true in 6 to 30% of adult cohorts. And this diagnostic yield is influenced by a number of things. First of all, the sample size of the cohort, the inclusion criteria of the patients, the specific phenotype of the patients, the specific next generation sequencing approach, and the selection of genes that were used in that approach. And what has come out of these different studies, that there are a few predictors of a high diagnostic yield. First of all, and this is presumably not so is very clear, is that if there is a family history of kidney disease, the diagnostic yield is higher. This is also true if the age of onset of the patient that is tested is young. If there are also extra renal features that point to syndromic causes, there is also a higher diagnostic yield, and it also appeared to sort of depend on the kidney disease type, as you can see in the right panel. So for tubular disorders, for instance, the diagnostic yield differs in different studies, but can be up to 100% of certain studies. Whereas, for instance, for focal segmental glomerulosclerosis, in some studies, it's only 22%. So there are certainly predictors of higher diagnostic yield. It's important to know that all of these data come from research cohorts. And actually, the important thing is how is the diagnostic yield when we see patients in the clinic? So we think that it is very important to incorporate next generation sequencing genetic testing in routine clinical practice. But especially in adult nephrology, we see that there are still main barriers to do so. It appears to be difficult for many nephrologists to actually identify what is the best diagnostic test for this individual patient. Some nephrologists also think, what is actually the added benefit of a genetic diagnosis? So what is the clinical utility? And of course, we must acknowledge that there are differences in accessibility and also insurance coverage for genetic testing. So in my country, in the Netherlands, every patient actually is allowed to have a genetic test, and this is completely covered by the insurance. But I know that this is not true in many other countries. Of course, many of the non-genetic professionals have limited genetic literacy and account difficulties in understanding the outcome of these next generation sequencing studies. And then there are all kinds of organizational issues. So how can we do proper genetic counseling, pre-testing, post-testing? What are the costs of the test, etc., etc. Then it appears to be rather difficult to actually interpret the identified variants, and we should pay attention to that too. And as said, there is certainly a real need for appropriate pre- and post-test genetic counseling, because there are ethical issues involved and there are psychosocial implications of genetic testing. And it is very important to communicate the results, the outcome of the testing in a meaningful way to our patients. So in our webinar today, we actually want to emphasize all of these important items in order to help you, to give you some guidance in performing these genetic tests in your daily clinical practice. So what we will do is we will discuss the different genetic testing modalities and their indications. We will show you what clinical information is actually important to allow a high quality interpretation of next generation sequencing genetic testing. We also show you examples of what is the exact clinical benefit of genetic testing, and we will emphasize the importance of pre- and post-test counseling and give you some kind of guidelines how to deal with that. And with that, I hand over to Andrew.
Thank you, Nina. So firstly, talking a little bit about some of the technology that we're using in the clinical genetic testing space, it's hard to start talking about this at all without really, I think, recognizing the elephant in the room, that there's been a fundamental and significant shift in the paradigm of how this is occurring over the past decade or so. We've really moved from a time of doing single gene by gene testing to now having capacity to have a single test for potentially all genes. And this looks like a few different things in different places. There are targeted phenotype associated multi-gene panels. There's also whole exome sequencing, which is really obviously sequencing of just the protein coding components of our genome. And then there's also, more recently, whole genome sequencing, which is captureless sequencing of all genetic information within the genome line. Nowadays, the concept of virtual panels, which was only really emerging, I think, at the mid-decade point, is really becoming quite standard practice in many parts of the world. And what we mean by this is that we filter the genetic information from either whole exome or whole genome or other next generation sequencing for the relevant genes for the phenotype in which we're seeing in that patient or that type of patient. And this really provides utility in some ways, but also, as we mentioned here, there is the potential for structured reanalysis if there's perceived change or reassessment of the clinical phenotype that is being seen. There are multiple different ways that we obviously undertake genomic sequencing, and all of these have different roles for different things at different times. And I think one of the key concepts for us as clinicians with genetic testing and genomic testing in our patients is right test, right patient, right time. So briefly walking through these, one of the more traditional sequencing approaches obviously is Sanger sequencing, and this is a quite appropriate approach for single gene disorders where there's a very clear clinical phenotype, where really there's only just that one gene that you're interested in understanding whether there's variation within it. Then obviously there's array-based genomic testing, and this is looking for large copy number variation. And this is potentially something that we see in more complex disorders like Kakut or nephronophthisis, specifically looking at things like deletions within the NPHP1 gene. Moving into probably the beginner steps of next generation sequencing, the targeted phenotype associated gene panels or targeted whole exome sequencing. This is a variety of different approaches that have been taken, and this really is best tailored to disorders where there's heterogeneity around the loci, where there's overlapping phenotypes. So actually, one is keen to broaden out the list of genes to encompass all of those phenotypes, And also there's perhaps common disease pathways with multiple genes associated. And some good examples of this are around steroid-resistant nephrotic syndrome, hereditary tubulopathies, and in many instances, complement-related disorders. Whole exome sequencing is obviously now playing a much greater role, and this is particularly useful where the phenotype of a patient or family is less distinct and the underlying cause is unclear. It can also be used as a second-tier test after more targeted testing, and there is a strongly emerging role in unexplained kidney disease of a suspected or otherwise heritable nature. Most recently, the new kid on the block, so to speak, is whole genome sequencing, which has been also emerging these last few years and is now in some locations globally clinically accredited. And this has a very interesting role, because in some ways this is almost the test to unite them all. It can do many different things that its antecedent tests could do. At the moment, its role seems to be very much in cases which remain diagnostically unsolved, despite a strong phenotype after perhaps whole exome sequencing, and the clinical use is being still explored. One well-established indication for whole genome sequencing is in autosomal dominant polycystic kidney disease, largely due to, obviously, homology with the PKD1 gene, which this approach is able to overcome. Whenever we're using different types of testing, it is always so important to frame the limitations. There is no such thing, I don't believe, at this time as a perfect test. That's actually true with so many parts of medicine, but it's also true of genetic testing. And it is so important to help our patients to understand, as well as our colleagues too, to be honest, that the outcome is not always linear. So some reasons as to why answers come back the way that they do. First of all, phenocopy disorders may be missed. You may have seen a patient who has what looks like a particular phenotype, and you hand on Bible, order a specific test targeting the genes that you believe are associated with that phenotype. But what if in this circumstance, the phenotype is actually a phenocopy? And in some good examples of this are things like cystinosis, hyperoxaluria, Fabry disease that at times can mimic inheritable forms of podocytopathies or nephrotic syndrome. Another thing to be aware of is obviously large copy number variations, and specific copy number variation detection algorithms aren't necessarily always performed in all settings with all of perhaps the more advanced forms of genomic sequencing that are available today. And some of our disorders, particularly as we mentioned here, HNF1B and NPHP1, respectively renal system diabetes syndrome and nephronephritis, actually have an appreciable proportion of cases due to whole gene deletions. So a negative result may not always be a truly negative result. It's important to ensure that this has been adequately encompassed. Variants in some genomic regions are also poorly discovered with whole exome sequencing and other massively parallel sequencing approaches, such as the first exon in COL4A3, which relates to Alport syndrome because of its GC content. And as we mentioned before, some issues obviously around pseudogenes in PKD1. Some pathogenic variants aren't discovered by any of our NGS-based approaches, and I can very much recall when I first saw the publication in the early part of this decade, when the MUC1 gene was discovered as a cause for what was then, I think in many places, being called 1Q nephropathy because of linkage analysis for many families with genetically unresolved autosomal dominant tubulointerstitial kidney disease, as we now call it. There can also be variants in non-coding regions, which often aren't analysed or perhaps even sequenced in some instances, depending on the sequencing approach. And this is certainly true for some deep intronic mutations within the DJKE gene, and also things like imprinting defects that can be seen with Beckleth-Wiedemann syndrome. So it's important to know all of these things, because these are almost like the road rules. If we don't know what we don't know, then it becomes very difficult, I think, to interpret what perhaps, say, things like a negative result means, and how negative is that really. Interpreting identified variants is also, I think, a really important point. For us as clinicians, when we order a test, we would really like to think that this is as simple and transactional as sample in, diagnosis out. And all of the stuff, for want of a better term, that happens in the middle, these wonderful white boxes, is all just a big thing, a big black box in the middle that we don't really get to see much of what's going on. Unfortunately, this is actually an incredibly complicated process between sample acquisition to report coming back to you. And it's important to be aware of this. Patients frequently will ask in regards to, say, time frames for test return. Why is it that perhaps, say, their serum creatinine can be measured within hours, but a genomic test takes 3 months? It is important to be able to explain that this is a slightly more complicated thing to be doing. Also, it's a good example of information in equals information out in many instances. So having good clinical information and phenotypic information does also significantly help with variant curation, as we'll talk about, I think, in the next few minutes. Variants that are identified as part of genomic sequencing are assessed in a very, I think, appropriately complicated way. Our genome is a complicated beast, and if it was easy to understand, well, everyone would be doing so. But it is clearly a very complex thing, and the way that we understand the meaning of genetic variants that we should identify as part of diagnostic testing is important to touch upon. Firstly, there's this very complicated interplay in terms of evidence across different domains for a specific variant, as well as the relative strength of that domain for that particular variant. As you can see in these cookbook kind of, I think, criteria that come from the American College of Medical Genomics, we can see that there are different ways to look at these genetic variants. And in fact, the combination of different criteria is what helps us to understand which class of variant that variant happens to be. This combinatorial strength is really what underpins the result that we'll come back to on that piece of paper or in that email when the result returns. And understanding that this has been quite a complicated process, and in fact, sometimes information that's being provided to the diagnostic lab does help them in terms of some of these evidence codes or evidence points for individual genetic variants is important for us to comprehend. In terms of the potential results that come back, obviously there's these classifications that we often see. So the most clear that comes back is a class 5 variant, which is clearly pathogenic, class 4, which is likely pathogenic, 3, which is of unknown significance, and then less rarely reported, or what we would see is class 1 or class 2, which is clearly not pathogenic or unlikely to be pathogenic. I think certainly from my experience, and I know from many others who I talk with, variants of uncertain significance are the trickiest. They're perhaps the unrequited result that comes back. You're expecting something that's clearly positive or nothing, and you get this thing that you don't quite know what to do with. Understanding this, what this means, and I think being able to communicate this back to patients is just so incredibly critical. And the most important thing here is that these variants may very well relate to the disorder, but they may also very well not. We just don't quite know yet. And in fact, working around the reason that it's come back as of uncertain significance in terms of the previous criteria can be important to unpack that, and also whether further investigation, either functionally with the family or in terms of getting other evidence points or segregation, may help to further clarify that significance, of course, in terms of the categories, the ACMG variant criteria that underpin that variant. The way that we get these results back, I think it's so important to understand too the different results, the potential results, and how we can handle these. I think within a multidisciplinary setting for interpretation of our findings, there are obviously in silico tools that we use quite often, and many of you are no doubt seeing those and using them perhaps as part of either research or certainly clinical activities. A key question to ask oneself is, can this variant explain the phenotype? And more so, does the variant actually also segregate with disease in the family? This requires discussion. And often this does require not just us as renal physicians, but also requires working together with our pediatric colleagues. Obviously, I'm an adult renal physician, but also pediatric nephrologists, our clinical geneticist colleagues, genetic counselors, and diagnostic genomicists as well. When we achieve a positive test, which really is that close association between a clearly pathogenic variant with a phenotype that's relevant, this establishes potentially the genetic diagnosis, and understanding what that should mean for the patient and the broader team is important. And then lastly, of course, a negative test result. It's so important if a patient or family has a clear phenotype to be able to explain that this doesn't actually exclude a genetic diagnosis. There are, as we mentioned before, a number of reasons as to why a variant may not have been identified. It doesn't mean that there isn't one there to find. It just hasn't been found now. It may be present and our sequencing technology can't see it, for want of a better term, or there is a variant present in perhaps, say, a gene that isn't discovered as yet. And so explaining to patients that a negative test result doesn't remove a clinical diagnosis in the vast majority of instances is very, very important. It can lead on to working out and determining as to the role of any further genetic or even functional testing that may be indicated too. And I think that this is sometimes it's the end of the beginning rather than necessarily the beginning of the end in terms of the diagnostic journey in some instances. As we mentioned before, the most challenging of results to deal with is the unclear results, the variant of uncertain significance. There's variability in different health systems, hospitals, and clinical practice groups as to how these are handled, whether they're even disclosed in some instances to patients. So it is important to touch base with your local multidisciplinary team to ascertain what the most appropriate local approach is. And specifically, I think as renal physicians, working with genetic counselors and clinical geneticists is quite important. Some key things from ACMG recommendations that should always be remembered by us, I think, in our practice is certainly that, first of all, these variants of uncertain significance should not be used in clinical decision making. And efforts to resolve its classification to benign or pathogenic can be undertaken, but obviously with forethought being put to that. And also, it may prompt further monitoring or investigation for the disorder which happens to be in question in that specific scenario. I think this is a really excellent framework for our approach to these variants of uncertain significance, because whilst patients can often be quite confused about them, if we also are, unfortunately, as renal physicians, inadvertently communicating that we're also confused, I think that is a major threat to the clinician-patient relationship and in terms of achieving positive benefit for patients and health systems from genomic testing in kidney disease. Nina, I'll hand over to you for the next section.
Thank you, Andrew. So as Andrew mentioned earlier, it is very important that before doing a genetic test with next-generation sequencing, the input of the phenotype is actually very essential to interpret the data that come out of sequencing. So as you are used to do with all other kind of diagnostic tests, it's of course important to have a complete and precise clinical phenotype, where things as age of onset of the disorder, for instance, is very important, because as I showed you before, the younger the age of onset, the higher the chance that this is a genetic cause. Results of additional investigations such as kidney function imaging or a biopsy, and also important earlier genetic test results are also important. And what is certainly important is the family history. So the best thing to do is really to draw a 3-generation pedigree and ask questions about all of the people in the pedigree, whether they have renal disorders or maybe extra renal features that might also point to some kind of syndrome with a renal disorder included. So what is very important to know is that many of the, let's say, in silico tools that are now present to interpret the variants that come out of next generation sequencing, these tools incorporate the patient's phenotype into these tools to finally make this interpretation. So again, pointing to the enormous importance of giving good phenotypic data. before testing. Most of these tools now require this phenotypic information encoded in so-called HPO terms, so according to the human phenotype ontology. And there are also HPO terms for renal disorders. Of course, it's quite a task if you have your clinical notes to sort of convert those clinical notes to HPO terms. If you have to do this by hand, it is a lot of work. But luckily, now there are tools being developed that actually automatically convert your clinical notes from your electronic health record into a list of the patient's phenotype in HPO terms. And I'm definitely sure more of those tools will become available, and hopefully it's possible that in your hospital, these tools will also be implemented, because that will make life much easier. So this is a real case that I saw in my clinic years ago, where I want to show you the importance of taking a careful family history. So this started all with a 30-year-old patient who was diagnosed in his childhood with cystinosis. And he came to me because he just had a girlfriend. They wanted to marry and have kids, and he wanted to have genetic counseling. So I took the family history, and as you can see, there were various persons in his family, all males, who had either end-stage renal disease and died from that at early age, or had kidney stones and decreased renal function. And this actually alerted me to, well, is there could there still be a connection to the disease in this patient? And of course, cystinosis is a recessive disorder. So this could still be the case, that this patient had cystinosis and nothing to do with all the other renal disorders in the family. However, I asked the ophthalmologist whether there were any cornea crystals in this patient, and there were none, which is rather remarkable for a patient with cystinosis. And then I performed a genetic test in a small panel, and this patient appeared not to have mutations in the cystinosis gene, but he had mutations in the CLCN5 gene, which is the gene that is responsible for dense disease. And this then made clear that this patient did not have cystinosis, but had dense disease, and that he had been taking cysteamine for his whole life until now for nothing. And you know that cysteamine taking is not nice, because this is has a nasty taste. And so this was really remarkable, both for the patient and for us, that this patient had a diagnosis for years and years, which was completely wrong. And if the family history would have been taken earlier, maybe the right diagnosis would have been made. And of course, we now could also give him a clear genetic counseling, again, because dense disease is an X-linked recessive disease. So showing the importance of careful family history taking. So this is another slide where, in spite of family history, sometimes the family history is completely absent. And this is also important to show you. So this is a patient, a male patient, who had end-stage renal disease by the age of 29. And on his renal biopsy, there was FSGS. And this patient came to our clinic because he wanted to know whether any of his family members could give him a kidney, could be a kidney donor for him. We performed a gene panel testing for FSGS in this person, a panel encoding 20 genes, and we found a pathogenic mutation in the INF2 gene. And this is known to be, INF2 is known to be an important gene for autosomal dominant focal segmental glomerulosclerosis. So this we thought was certainly the cause of the disease in this patient. And then we tested his family members. What we saw is that his brother didn't have the INF2 mutation, and his father also not, but his mother appeared to be a mosaic for this mutation. And so she had the mutation in 20% of her cells and not in 80% of her cells. And of course, in this mother, we performed extensive health screening, and she didn't have any abnormalities in her kidney. And also, she didn't have any neurological abnormalities. And why did we think of neurological abnormalities? Because the INF2 mutation may give a syndrome that combines focal segmental glomerulosclerosis with a neuropathy called Charcot-Marie Tooth disease. So this is a neuropathy mainly in your distal extremities with weakness and sensibility disorders, and sometimes may also be associated with the deafness. She didn't have all of that. Also, our patient didn't have neurological abnormalities, so there was really a isolated renal disorder in this patient. So there was no family history, but in fact, the mother did carry the mutation, as you can see. So the child of this patient will be screened for proteinuria from the age of 7. And of course, when he's old enough, we can do genetic testing in this patient too. And for the next pregnancy, there are capabilities now, possibilities now to do genetic testing either by prenatal diagnosis or by pre-implantation genetic diagnosis. And the patient and his wife chose for the latter. So if we look to why is genetic testing important, there are many things to mention. And first of all, it is important to establish an accurate diagnosis. And of course, this may be possible by clinical testing or by doing a biopsy, but we've seen in many cases that genetic testing might end a endless diagnostic odyssey quite easily. We've also seen, and I'll show you an example in a later slide, that sometimes it's even better than doing a renal biopsy. And of course, this is always a matter of discussion, I know, among nephrologists and geneticists, whether or not we should do renal biopsies in our patients, and in what case we should and in what case we should not. So this is a matter of debate that will go on for a longer time, I think. And I show you examples of that too, is that if you have a genetic diagnosis early, you can also really do so-called reversed phenotyping and look whether there are any potential extra renal features that you should know about. Once you have a molecular diagnosis, there are also benefits. Again, because there might be a precise distinction between overlapping phenotypes, it might facilitate personalized management and prognosis, defining the prognosis. It is, of course, very crucial for genetic counseling and offering of potential reproductive options. It is important to screening at-risk family members, and that again is also important to determine the eligibility of potential kidney donors in the family. And finally, for more a research kind of, first research kind of option is that it may stratify patients for potential therapeutic trials in future. So this is an example of an end of a diagnostic odyssey in a patient aged 45, known with proteinuria, microscopic hematuria and hypertension, and a slightly decreased renal function. His mother and brother also had proteinuria, and of course this points to genetic disorders. And you might think of Alport syndrome in this family. There was no deafness in the family, and also the renal biopsy didn't show any signs of Alport, but showed focal segmental glomerulosclerosis. So we performed a panel sequencing in this patient. Is the nephrotic syndrome FSGS panel. You can see this is 74 genes and also includes the collagen genes. And with this panel, we found indeed a collagen 4A5 mutation, as you can see in the slide, that then was confirmed by the well-known Sanger sequencing. So really showing that the NGS was right in this person. So this patient indeed did have Alport syndrome. And that was important to know, also in terms of looking at the family and genetic counseling, etc., etc. So important also is that I mentioned before the discussion between renal biopsy and genetic testing. And in a very recent study that we have performed, and this study is in press in NDT. What we did is we actually looked at a large group, almost 300 transplant patients that had their transplant, who had their transplant before the age of 50. And we looked whether in these patients we could find a genetic cause of their end-stage renal disease. And we tried to not to have too many inclusion criteria. So just like you see in your normal clinical situation, you don't look at any inclusion criteria for genetic testing. So we tried to do a study that looks almost like clinical implementation. And so the only patients that we excluded were those patients that we had no longer contact to because they had left the hospital after transplantation. Those with a clear-cut non-genetic renal disease, for instance, an infectious disease or a nephrotoxic drug use or diabetic nephropathy, or patients where the DNA that was available in these patients and that actually came from previous HLI typing for the transplantation was not sufficient or of not sufficient quality. So in the end, of those patients, 174 patients were left, and in a part of these patients, and namely 40 of those patients, there had already been a genetic test that led to a molecular diagnosis, but in 70 of those patients, there was no genetic diagnosis, and we performed this large virtual gene panel of almost 400 genes, renal genes in these patients, and then got another diagnosis in 17 patients. So altogether, we had a molecular diagnosis in 57 of these 174 patients. And what was also important to know that in 6 of these patients, we had reclassifications from the original histological diagnosis. And this is just to show you some of those examples. So what we did, there was an original histological diagnosis, and we asked the pathologist in a blind way to re-examine the histological diagnosis of these patients. And the pathologist did not know that either that there was any molecular diagnosis nor what the diagnosis was. And we just asked him, what do you think, based on your re-examination, is the likelihood that this patient has a monogenic kidney disease? And as you can see in the first 2 patients, he couldn't determine this because there were no immunofluorescence or electron microscopy data. But in 4 patients, he said, well, it's not very likely that this patient has a monogenic kidney disease because he has secondary FSGS or he has IgA nephropathy or he has diabetic nephropathy. However, in these patients, as you can see, the first one had an INF2 mutation, so clearly monogenic disease. The next patient had a PAX2 mutation, again, clearly monogenic disease. The third patient had a COL4A4 mutation, identifying Alport disease. And the last one had cystic fibrosis, in fact. And in this patient, in the first diagnosis, original was nodular glomerulosclerosis. And this may mimic diabetic nephropathy, and that actually was the diagnosis by re-examination. And in only 2 patients, the pathologist said, well, it's very likely that this patient has a monogenic disease because there's diffuse mesangial sclerosis, or in the other patient, there's clear Alport syndrome. And this matches indeed the molecular diagnosis, the first one with podocin mutations and PHS2 mutations, and the second one with mutations in the COL4A3 gene. So again, you can here see that sometimes the molecular diagnosis really is far more strict, showing to the cause of the disease than is the histological diagnosis. An example of reversed phenotyping is this second case. So we had 2 patients, a brother and a sister, that had intellectual disability. They were both obese and had large heads. And we didn't know what they had, so we did whole exome sequencing in these patients. And as you can see, by whole exome sequencing in both patients, we identified homozygous BBS1 mutations. We also find some variants of unknown significance in other genes, but important is, so both brother and sister had the same homozygous BBS1 mutation, in fact pointing that these patients had Bardet-Biedl syndrome type 1. And what we know of Bardet-Biedl syndrome is that these patients usually have renal abnormalities and retinal abnormalities. So we did imaging of the kidneys and sent them to the ophthalmologist. And indeed, we found that the brother had renal cysts, and this was not known before, and he had severe retinal abnormalities that predict that he will be blind in a few years. And the daughter, the sister, also had retinal abnormalities and no renal abnormalities yet, but we will, of course, follow her for the appearance of renal cysts, which is very likely. So this is a very nice example where a molecular diagnosis helps you to find additional findings in these patients, and hopefully much more earlier, that you at least might help people, especially when they develop retinal abnormalities. It's important to help them because they will become blind in the end, and that they can at an early age try to adapt to the coming blindness. Another case of the importance of doing a genetic diagnosis is this family. You can see that there are many patients with a Kakut-like phenotype, renal dysplasia, unilateral or bilateral. What we often see in Kakut families, that there is Kakut phenotype, but there is difference in the severity of the symptoms that we see often in these families. And in the father of this family, so the first patient of the family, we did a multi-gene panel sequencing, and we found a PAX2 mutation in this father. His both parents didn't have this PAX2 mutation and also had a normal ultrasound. So this was then for us an indication to send these patients to the ophthalmologist. And what we indeed found is that these patients have a optic nerve coloboma, and so they do have renal coloboma syndrome. So again, a nice example of the detection of extrarenal features in these patients with Kakut. The next example also is important of clinical utility, and this is actually a nice example of clues for management, and the example is the nephrotic syndrome. So in the recent years, after the initiation of next generation sequencing, you see that an enormous amount of novel genes for nephrotic syndrome were identified. And actually this list is already outdated because almost every week or every month you see a new gene for nephrotic syndrome coming up. But nevertheless, there are a few genes in this list that are interesting because they have a relation to the coenzyme Q pathway, like ADCK4 and the CoQ6 gene. And so what we have seen is that patients with these causative mutations in genes in this coenzyme Q10 pathway, that they may benefit from coenzyme Q10 supplementation. So that's an important thing to know. What is also very important is that we now know that patients that do have mutations in any of these genes associated with the nephrotic syndrome actually do not respond to steroids or any other immunosuppressive agents. So that's important beforehand. If you know that, it is almost useless to use these agents in these patients. And also it's important that if you do transplantation, that the recurrence in patients of disease is very low, and which is in contrast to patients with a non-genetic cause of nephrotic syndrome, where you see that the recurrence after transplantation is much higher. Finally, also important for the genetic testing nephrology is actually to look at the possible eligibility of donors in the family for transplantation. And so this is also an actual case of us where we had these two brothers with Alport syndrome, and they, of course, were looking for a donation of a kidney, and both parents felt that they should each give one kidney to each of their children. However, when we did genetic testing, we found a COL4A5 mutation, of course, in these 2 kids. That was expected. And also is that the mother appeared to be a heterozygous carrier. And so this meant that she could not be a kidney donor for both of her sons, and only the father was available for giving one donor to one of his children. And you can imagine how morally difficult it is then to decide which of the sons get this kidney, and how can we maybe in the family find another person who could donate a kidney to one of the other kids, to the other kid. And with that, I hand over again to Andrew.
Thanks so much, Nina. This last section, I think, is really important because we've spoken a lot tonight and today around the test itself and when to do it and how to do it and things like that. But there's also this whole, I think, almost cloud around doing genetic testing, which isn't necessarily always as well understood by us renal physicians, which really we have a big buy-in about. And this is around pre and post-test genetic counselling. So first of all, to get I think the biggest elephant possible out of the room, yes, we as nephrologists, we can order NGS-based genetic testing. It is within our remit, and particularly for symptomatic patients for diagnostic purposes after appropriate counselling, and of course, most importantly, informed consent. So this is within our scope, within those bounds, and it's important for us to, I think, realise that. The next important thing is, as we've mentioned, around some of the pitfalls. The larger the panel of genes that you're ordering a genetic test on, or if indeed you're doing a whole exome or whole genome with full exome and full genome analysis, the risk of things like incidental findings does go up. So in this instance, it would be recommended to consider consultation with a clinical geneticist. Orders should also be accompanied, as we've said a number of times, with as much detailed phenotypic information as possible, and/or direct intercalation with, as part of a multidisciplinary team, with your reporting diagnostic laboratory. Lastly, in many countries and many jurisdictions, the ordering of pre-symptomatic genetic tests for asymptomatic or at-risk individuals in many countries is actually reserved for clinical geneticists, or is actually largely preferred to be done by clinical geneticists due to legal, practical, and accreditation requirements. And this, I think, is, the instance of, I think, using the example that Nina had before. If you should see a patient who has Alport syndrome, and they have a child, a parent, or a sibling who is completely asymptomatic, showing no signs of a condition, doing a predictive genetic test in that individual is, in many instances, largely the remit, actually, of our clinical genetics cousins. In terms of some practical recommendations for pre-test genetic counselling, it is so important to inform our patients of the possible outcomes of the test, including the possibility, of course, that the test may not have a positive outcome. I think there's nothing worse than setting our patients up for failure by giving them an unreasonable expectation that there will absolutely be a positive result. Emphasising that the genetic diagnosis may, but not always, lead to a change in management or the prognostic circumstance. Mentioning the potential psychosocial consequences as well of receiving a definitive diagnosis. The ending of a diagnostic journey is a very complex beast. And I certainly have seen myself, and I'm sure Nina, you have as well, that the impacts of a definitive diagnosis, or even sometimes the absence of a definitive diagnosis in a testing algorithm, can be nuanced. And it really does often rest, I think, on that relationship that we as clinicians have developed with our patients. Mentioning also the potential implications for insurance and insurability wherever that patient and their family may be at that time, I think, is quite important as well. And that varies by diagnosis and situation. Discussing the possibility of, obviously, variants of uncertain significance and incidental findings, depending on the type of testing that's being done, as well as their implications for the patient themselves, their family members, and whether there's any hospital or jurisdictional policies in regards to how these are handled. Incidental findings in genetic testing, particularly when we're using NGS, is an emerging space. And I think in terms of what we mean by this is, say, you do a genetic test for disease X, but instead, inadvertently, a variant in gene Y is identified that doesn't correlate with the reason that you've done that test, okay? And we would generally predict the frequency with which this might be seen, say with whole exome or whole genome analysis, is somewhere between 1 to 3% for an actionable incidental finding. It can have implications for broader family members, and obviously genes like BRCA1 and 2 have become much more, I think, well publicised in recent times, and there are significant ongoing debates around the general approach, and there are jurisdictional dogmas certainly around this too. In North America, the American College of Medical Genetics and Genomics has a list of 59 actionable genes. So you may hear of the ACMG 59, as we sometimes call it in short term, which are actionable incidental findings. There are different attitudes to this. So for instance, where I am in Australia, as part of standard diagnostic testing, we exclude those genes generally, unless from our analysis, so long as obviously the disorder of interest isn't one of those actual 59 actionable genes. But in North America, in many instances, they're embraced and seen as representing potential value. In Europe, also, there are emerging regulations and recommendations around restricting analysis and testing to the regions of the genome specifically only related to the patient's phenotype. And none of these policies really have been generally necessarily accepted for wide-scale use across jurisdictions or even homogeneously within jurisdictions. So, you know, this is a great, I think sometimes also discussion starter with your local genetics colleagues if you're cutting your teeth getting into this space. And it's good, I think, always to listen to what their experiences may be and what those things are that are framing what their local recommendations might be. Post-test, in the case of, you know, obviously a likely or absolutely pathogenic genetic variant are being identified, providing information on the associated condition is so important. I think that's quite normal and natural, as well as, you know, what that should mean prognostically, as well as in management. Sometimes there can be no change of management, as we said before, but sometimes there's a frame shift in management. I think explaining that can be important too. Some of the examples that Nina presented too, sometimes our patients are given a specific diagnosis and that becomes almost part of their identity. If that is then obviously removed or corrected as part of this, helping them to also transition from that previous state, including the change of management, can be very important. Consider having a clinical geneticist or genetic counsellor on your team, on your side, there, particularly for more sometimes tricky kinds of results that might come back, and also particularly when there are specific concerns or queries that have been raised around things such as recurrence risks after transplantation, recurrence within families, at-risk family members, reproductive options as well. I think as renal physicians, things like reproductive planning are also within our clinical remit to begin discussions with patients, but we work as part of teams. So also involving clinical geneticists and genetic counsellors as part of completing those discussions is just so critical. Discussing the implications for family members and providing a supportive construct for that to be actioned over time is important too. And as we mentioned before, with variants of uncertain significance, if there may be further functional investigations to undertake, obviously ensuring that those are undertaken and interpreted in a timely manner. So summarising the results and genetic testing utility and follow-up, as we mentioned earlier, there's the positive test result, which establishes the genetic diagnosis and is a result of likely or pathogenic variants related to the phenotype of this specific patient. Things to consider here as well are implementing treatment and surveillance if and as appropriate. I care for also a large cohort of patients with inheritable kidney cancer syndromes, and so surveillance is core to their primary diagnosis. Implementing genetic testing of family members if and where appropriate in consultation with other members of the broader team is critical, and discussing reproductive options where appropriate. And this may sometimes take us asking open questions to facilitate that discussion happening. In terms of negative results, where either there's no variant identified or benign or likely benign variant identified, concisely and clearly communicating that this does not rule out a genetic diagnosis for the reasons we've already discussed today in that context, and determining if there may be a role for either additional testing at this time or whether revisiting the diagnosis in several years with obviously updated sequencing approaches and new phenotypic approaches, and also prescribing time for phenotypic evolution. In terms of the ambiguous result, these pesky VUSs, as we keep saying, considering the strength of the association with the disease phenotype and talking with your colleagues to work out what the best plan of action is here and how that's going to be communicated to the patient so that, really they do get a message which is cohesive and accurate for their circumstance. Feeding back any incidental findings, I think, is key to go into that discussion with a game plan. So having a decision around feedback which is determined by your local policies, and there's actually also been to some degree discussed at the point of informed consent, depending on the test that you're doing. I couldn't emphasize enough that I think in this circumstance, if there is an incidental finding to be reported back, this having been discussed with your colleagues first to ensure that this is reported back in a sensitive and appropriate way, providing support and a meaningfully appropriate, I think, screening strategy moving into the future. So some gaps in knowledge and spaces for us to develop in terms of research, and obviously this has been a session all about clinical genomics. This is the research components within what we've been speaking about in this session are small r research. This is capital C clinical. First of all, increasing genetics literacy amongst clinicians, that's the bread and butter of exactly why we're doing sessions like this. It is so critical, and we're so excited to see so many of you all around the world getting involved in this space. There are great resources available, such as obviously the Genetics Education Unit in the United Kingdom and others too in your jurisdictions and in other languages. There is practice-based education and these communities of practice amongst nephrologists with their colleagues and clinical geneticists. And I think establishing those locally and tapping into those knowledge networks is important. Optimizing the accuracy of our variant interpretations with our diagnostic labs. I can assure you, our diagnostic genomicists do not bite. So they are great people to make your friends. Working with them, I think, certainly helps our understanding as clinicians, but it also results in improvement in the bioinformatic algorithms that they are using over time, as well as sharing of the genomic data in things like ClinVar at a global level. This preserves patient privacy, so our patients, we should be communicating this to them, but it will improve the genomic endeavour at a global scale quite significantly over coming years. Lastly, the validation of research findings in routine healthcare settings. Now, there are large-scale studies of ethnically diverse chronic kidney disease patients, which are defining the exact indications and diagnostic yield of genetic testing. And this is being used really to help guide our guidelines as we move towards this effective implementation of NGS-based diagnostic testing. And I'm a massive fan, I think, at this point in time, around a learning healthcare system model where we do things, we learn from those, and then we implement those learnings back into our practice and then repeat. And I think that this is a great space to approach this, but we are now moving into a clearly clinical implementation framework. Understanding the costs versus benefits in genetic testing, I think this is a really challenging space. We're only at the very beginning of starting to understand this, and there's not as many studies globally, I think, looking at this as we would like there to be. So I think this is a really exciting thing to be seen to begin to happen. Also, in terms of the time horizon here, long-term versus short-term outcomes and effects from health service utilisation is important. Health technology assessments, the different sequencing approaches we use have different cost bases, for instance. I think understanding those is important so that we find equipoise in a diagnostic sense. The organisational and counselling support is critical here. Developing our clinician decision support tools. Nina obviously mentioned things that are interacting with our digitalised healthcare environment increasingly. The role of genetic counsellors in nephrology practice, whether they're obviously in with us in clinics seeing patients or whether they're consultative, what their role is. I'm a very pro, I think, a clinician in this space, thinking that there are innumerable roles that they may play, but to each their own, and each, the local circumstance that you might find in. But, you won't find utility where you haven't looked, I don't think. Understanding our computing platforms to facilitate integration of our genomic data with electronic records. Large-scale data is complex. Finding ways to make it knit together to make sense is really going to be the next challenge over the coming decades for us in healthcare. The key take-home message, I think, take-home messages for us today, so boiling it down to 4 main points. The first is around different genetic testing modalities and their indications as we run through, with the core guiding dogma of right test, right patient, right time. Secondarily, clinical information that is needed to allow high quality interpretation of these next generation sequencing tests. There's clinical accreditation. That's key to clinical testing, and look for it and understand it in your setting. Phenotype driven diagnostics, and that this is a multidisciplinary game. Fundamentally, playing with others is so important to realizing the potential here. Thirdly, the clinical benefits of genetic testing. These are strongly emerging at this time, and I think at this point likely undeniable. They can both be direct and indirect. And it's important to also think about the different paradigms of clinical utility versus diagnostic utility. These are different. And as we kind of began to hint upon, sometimes a negative result has positive clinical utility, and this is an evolving space. Fourthly, there is strong importance around pre and post-test genetic counselling. It's critical to realise the utility. It sets us up for success. It sets our patients up to get positive outcomes, regardless, to be honest, of what the test result actually might be. And it's a great opportunity for us in our ongoing continuing medical education framework. And with that, I think we've come towards the end of our session for today. It's been wonderful to obviously be presenting with Professor Knoers. It's always great to talk through cases together. And obviously there are some questions that we're only too happy to walk through. So Nina, we've got some really, I think, great questions here that have been sent in for us to look at the end of this webinar now. And I think it'll be a lot of fun as we walk through them together. The first one I might actually pose to you, if that's okay. So it's really saying, it's a statement first, for the majority of these genetic kidney diseases, the clinical utility of the genetic testing is known. Do you think that's really the case at this point in time?
Well, it's a very interesting question, and as a geneticist, I would hope that this is the question, but that this is the case. But I think, in fact, it's not yet. It also, again, like we said in the webinar, I think there is a difference between the clinical utility and the diagnostic utility. So in terms of diagnostic utility, I'm really very optimistic about the use of genetic testing. I think, we've shown many examples, and there are many, many more that, especially under the age of 50, I think genetic testing in patients with renal disease, where you really have excluded some of the clear non-genetic causes, there is a case for genetic testing in diagnosis. But we have also shown in the webinar that it will take follow-up studies in the real clinical world in these patients to finally define for which of the patients this really has benefit in terms of management, in terms of surveillance, in terms of prognosis. So in that sense, I think we could not say the majority. For a minority, yes, but for the majority, again, this needs additional studies. But also, of course, with the more knowledge we have about these genetic diseases and understanding their pathogenetic mechanisms, we might also come up with novel therapies. And then, once that's there, then genetic testing again has an important role in clinical, has an important benefit, because then you have new therapies, and then you again first need to have a molecular diagnosis. So in time, this will certainly change, but at the moment, I think it's honest to say not for the majority yet.
Yes, I'd certainly agree with that. I think it's diagnostic utility and clinical utility are similar but different, and I absolutely agree with you. It's so hard for us to comprehend treating what we don't yet understand, and we do need that understanding to drive that into the future.
Yeah. So maybe Andrew, could I ask you a question that came up from the audience? So of course, many of us see patients with autosomal polycystic kidney disease, and we know these families, the families themselves know that. They say, well, you know, my father had it, my grandfather had it. So what is the added value of genetic testing? So in other words, do you think that in these patients there is added value to test genetically?
So in specifically patients with polycystic kidney disease, in ADPKD?
Yes.
Yeah, I mean, this is a fascinating question. It comes up all the time, and it's a great almost teaching point, isn't it? Because there is this sense that because you have access to a thing that you should be using it for everything because it's so great. But a core thing, at least in my practice, and you know, my mentors in developing my skill set, is around a key tenet of genetic testing is there has to be a question that you're asking. What's the point of doing this? Just doing it for the point of doing it may not represent any value. And obviously with ADPKD, we've got very well established imaging-based clinical diagnosis algorithms and rubrics to assess our patients. So if you already know that they have ADPKD based upon their ultrasound or other imaging study, would a genetic test add much to that? And I explore that with each individual patient, and I've cared for quite a number of ADPKD patients, including a lot of atypical patients in my practice. And I think that for each patient, it looks different. I'm someone who is, I think because of my skill set, I'm more comfortable with ordering genetic tests in this space, but I would never order one for a patient with ADPKD in the absence of a clear reason to do so. And the reasons that often appear are probably much like you see as well in your practice, you know, patients with active questions around reproductive planning, patients with a clinical presentation which is kind of in the grey space. It's not quite clear. So someone without a family history, with more than 10 but less than 20 kidney cysts, and they're not quite fitting into the consensus diagnostic criteria at this time, a genetic test can be very helpful for those patients. Sometimes, and I have actually been, an interesting story, I have been confronted by this once, a patient who wanted to understand their prognosis because their employer was self-funding their life insurance. They also happen to be a lawyer, I will say that, which always makes a consult just a little bit more, you know, high stakes. But I think in that setting, you know, we discussed at length the value of, say, a pro-PKD score, because that had just been validated actually not too long before, and would that provide value for this patient who didn't have much family history to guide prognostication, and they were a younger person still at that time. And so we did the genetic test, and it did provide value for them, in fact, in terms of guiding prognosis, and that was a valid question for them. But you know, I think it does so much rest upon what is the question you're asking, what's the point of doing this, exploring that with that individual patient, ensuring that, you know, for that value-based healthcare model, it's always being done for a clear and appropriate reason. And particularly in ADPKD, I think it's a great commonly seen example that teaches us so very much around how to do that. So do you see many cases like this as well, Nina?
Yes, well, of course, the patients that we see with ADPKD come to the genetic clinic, especially because they have questions about, you know, recurrence risk or especially reproductive options. So we have seen in the Netherlands an enormous increase in patients who go for pre-implantation genetic diagnosis for ADPKD. And that was also surprising to me because, you know, being in contact with nephrologists for a long time, many of the nephrologists say, well, they are not interested in this. They know this disease and they know they will have end-stage renal disease by that and that age, but it doesn't prevent them from having kids, etc., etc. But this appeared actually not to be the case. So if people really understand what is going on by genetic counseling, understand the recurrence risk, but also that there are options to prevent having a child with ADPKD, that was knowledge that is very important, and now we see an increasing wish for patients to have such a pre-implantation genetic diagnosis. Certainly.
Yes. Yeah, it is that critical transition as well, where and we explain to our patients quite a lot here that Our role is to provide as much information as possible and support and guidance, but fundamentally, we're not the decision makers. Exactly. Our patients are the decision makers, and so for us to presume what they want is actually quite arrogant. We can empathize and everything, but you're absolutely right. Practice patterns are changing, and it's great to see genomics, I think, fitting into that, particularly in ADPKD.
Yeah.
There's a fantastic question here I'm dying to ask you, Nina, because I think it's a hot button one, given some recent work in the last few years. What do you consider that diagnostic genetic testing in all patients with CKD of unknown origin is indicated today?
Yeah, again, very interesting question. I think from many of the research data, there is clearly an indication that there is high diagnostic yield in patients with CKD of unknown origin. But again, for all of these research data, the question arises, is this not a pre-selected group where, the likelihood of getting a genetic chance either by family history or by extra-renal features or by the type of kidney disease has actually led to this high diagnostic yield. And this is why we did this study I mentioned in the webinar, where it was a rather unselected group. And I think, again, if you say all patients, that is, I think, too much, because again, in the most older patients, there is a higher chance, I think, of having diabetic nephropathy or another non-genetic cause of renal disease. And the same is true if there's clearly an infectious disease or there's clearly, there's clearly nephrotoxic drug use that can lead to renal function decline. I think in that case, there is not so much an indication to do genetic testing. But in many of the others, yes, and especially if there is, severe, and again, also the severity of CKD, I think in stage 1 or 2, there is not so much reason. So it should be a severe CKD or end-stage renal disease, going to end-stage renal disease where this makes sense. And then again, excluding those cases where it's clearly non-genetic. But that is still a large part, as we have seen in many studies and also in our recent study.
Yes. So
I definitely, I think in any patient you get in your clinic, you at least have to think about, just think about with any patient that is in your clinic, is there in this patient an indication for doing genetic testing? And I think that's also a real paradigm shift in thinking that, I don't think that the nephrologist at this time does that in every patient with CKD. Ask himself or herself the question, should I do a genetic test here? And I think if we start doing that, and well, we might, I think that's important, that we might really get a change.
So Nina, that's the end of the questions that we've had sent in to us. It's been so fantastic to do this webinar together with you, and obviously to go through these questions. I know we always talk on the sidelines of conferences and wherever we should happen to be, which is always such great fun. But thank you so much for taking part. As always, it's so great to talk through these things with you.
Thank you very much, Andrew. Same to you. It was a great pleasure to do this together, and I thank the audience also for the nice questions we received, and it allowed us to, to talk a little bit further on, the difficulties that we still encounter, and the questions that hopefully we'll answer in the next future, the next 5 to 10 years, hopefully.
Absolutely, absolutely. Such exciting times. Thank you, everyone, again, and have a great day.
Bye-bye.
Thank you again for joining today, and you may now disconnect.